found a positive bleeding on probing on sites where no proximal box elevation was performed. The second study is a study from the Netherlands, from the group of Bresser, and they evaluated almost 200 restorations. They had 8 absolute failures, which resulted in a cumulative failure rate of 96%, which is rather high after this time. They said, okay, a root canal treatment does not affect our results, and also the kind of material that we chose for the coronal restorations did not affect the outcome of the study. But what they said is that restorations that had an intraoral retention time that was longer than 3 years, that these restorations sometimes suffered from marginal discoloration. They saw that there were fractures or secondary caries. And interesting in this study was that they found no significant difference regarding periodontal health. And another very nice study recently published by the group of Bertoldi was conducted like this, that also a proximal box elevation was performed. And that means composite was placed in deep subgingival defects. And after 3 months, they collected tissue samples from this site, and they compared the degree of inflammation at the restored versus the unrestored sites, and they could say that the inflammation degree was on a similar level. And now some of you might have been wondering, why do we pre-treat the composite build-up, especially in the proximal box? Well, we do this because we also do a lot of composite repair in our clinic, and the knowledge which we have from the composite repair procedure and from the literature can be transferred to the proximal box elevation technique. So what we know from this procedure is that a surface roughening should be performed. It's beneficial. You can do that either with aluminium oxide, 50 micrometers, or with, for example, the cojet system, which has particles of a size of 30 micrometers. If you go for sandblasting, please do it before you etch the enamel, because if you do it vice versa, then you have the problem that the etched enamel might be destroyed by the sandblasting. Then you should always use an adhesive, and you can apply a silane, although this topic is discussed a bit controversially in the literature. If you use a silane, you might know that from the clinic, for example, when you do repair procedures, it's really impossible to just place the silane on the restoration. You always touch the dentin to some extent. And we did a study in our clinic, and there was also another study published by the group of Chen, and both studies found out that a so-called silane contamination of the dentin does not affect the bond strength. Here is another case. This is a student of ours who had a problem with this filling in this premolar. You can also see, if you compare this papilla with this papilla, that here is some inflammation. And then if you check the X-ray, you see why we have a rather large gap here at the margin in the proximal box. So this build-up or this composite filling was removed. It was a really deep cavity. I again used the modified matrix technique. I placed the matrix and I couldn't place a wedge, so I solely placed Teflon tape. And you can here already see the problem. The focus was to keep this working field here dry. And if I wanted to keep it dry, I couldn't reach, or I couldn't create a proximal contact. So this is the build-up. Of course, this is not sufficient, but this is only the build-up, which will be covered by an indirect restoration, and you can see the margins are sealed. Then the preparation of the defect. I again went for a CAD/CAM procedure, and this is the defect isolated before the cementation, the adjacent tooth isolated by Teflon tape and selective etching technique. And this is the restoration directly after placement. Then only 4 years later. Of course, this is not relevant, but now in March 2029, this year, I did the last control. So this technique, as you saw, it's a very nice technique, which has some advantages, but also some disadvantages. The advantage, of course, is that you can place an indirect restoration in a defect where it would be primary impossible. So after just using a direct technique and elevating the margin, you are able to place an indirect restoration. And if you go for a partial crown, of course, this procedure is less invasive than if you placed a crown. You don't need any subgingival preparation margins, which also, of course, eases impression taking, and you don't need any orthodontics or surgery. But of course, this technique also has some disadvantages, especially the placement of the matrix can be very time consuming, and I have cases where it took 20 to 30 minutes to just place the matrix, which in the daily practice it's a huge amount of time. And of course, your working field has to be absolutely dry. You cannot make any exceptions there, because otherwise this technique is not going to work, as all adhesive techniques are not going to work if you have not an absolutely dry working field. You might have problems with polymerization because the box might be very deep. And as I just showed you, the amount of data that we have at hand is limited, especially if we go for the clinical studies. And I want to close my lecture with my favorite case. This was a patient, 85 years old, who had several veneers and crowns in the upper jaw. And you see, of course, the problems. Gingiva inflammation is very high due to caries at the margins. And this patient said, well, I'm 85 years old now. I don't want a completely new prosthetic treatment. I just want some small things. So can't you do anything about this? And I said, well, we can try to repair it. There was also a defect here. And what we did then is, you might realize, this is the picture which I showed you regarding the contamination. I went for a repair procedure. I shortened the margins of these veneers, removed the caries. I placed some retraction cords, and then I used a lot of astringents. I had to use a lot of astringents, and I went for an etch and rinse approach. I also etched the ceramic with hydrofluoric acid, but this was an hydrofluoric acid which which we are allowed to use by the manufacturer in the oral cavity. But nevertheless, you have to be careful with this step. These are the restorations placed and the restorations after polishing. Of course, the gingiva does not look nice. But then if we go for the first checkup, this is again the treatment. This is again before treatment. And then the first checkup, we had a bit of a time distance between these two checkups due to the lockdown, because this treatment was done directly because our first lockdown due to the corona pandemic. And this is then the first checkup. You can see that the gingiva is really in a good, healthy state. And this was the checkup in October. And again, gingiva is in a good state. And also the patient was instructed regarding oral hygiene, and she was very, very compliant. And this is the palatal view. So if we ask ourselves now if we can restore the unrestorable, well, of course, we are not wizards, we are dentists. But with the tips and the tricks that I showed you, I think that you can, in many cases, go for an adhesive approach and restore these defects. So thank you for your attention. I'm now looking forward to the discussion, and please stay healthy.